Hi guys, welcome back. Today we shall be talking about hepatorenal syndrome, which happens to be a complication of decompensated cirrhosis. This medical condition will be characterized by development of oliguria or anuria in a person with liver failure, which is primarily because of the toxins and due to imbalance between the vasoconstriction and the vasodilatation mechanisms in the body. Well, first of all, we should try and remember the incidence of this condition, which is a huge 40% of total patients of cirrhosis with refractory ascites. Now, mind my words here, I said patients of cirrhosis with refractory ascites, so it's not that I am saying that every cirrhosis patient with ascites would be having it, but those with refractory ascites, the definition I just explained to you, would be having this particular manifestation. On histopathological examination in this particular condition, on light microscopy, the kidney parenchyma is perfectly normal, so there is no glomerular changes, there are no tubular changes in this condition. Why? Because the problem lies with the liver, and it's because of the imbalance, as I said before, between the vasoconstriction and the vasodilatation occurring in the body that would be affecting the blood supply of the kidney. But per se the parenchyma remains normal in this condition, and the highlight of this condition is that the moment you will do a orthoptic liver transplantation, there is a restoration of the function of the kidney on a OLT. What I mean by the word OLT is orthoptic liver transplantation. So just have a look at the definition once again. This would be encountered in patients of refractory ascites. Parenchyma of the kidney is normal and the kidney function comes back to normal with orthoptic liver transplantation. Now let us understand the meaning of the word refractory ascites, which will make things relatively easier for us. You are aware of the fact that for management of ascites we need to go in for salt restriction, and most patients on Indian diet are taking something like 6 to 8 grams of salt every day. We need to put them down to about 2 grams of salt, and we also need to give diuretics. The diuretic we usually use and is the preferred diuretic for hepatorenal syndrome is spironolactone, and the dose that we give is about 100 milligram, but in this case we are giving up to 400 to as much as 600 milligram every day. That is to the maximum dose of spironolactone that I'm talking about, and simultaneously we are also giving a loop diuretic by the name of furosemide to the patient. The dose of furosemide that you're giving is up to upper limit of something like 160 milligram per day. So you are using 2 diuretics in a patient, and this patient is compliant with a salt restricted diet. So you can see that I've said 3 things. You are giving up the max dose of spironolactone, max dose of furosemide with the salt restricted diet, and still the ascites is present in the patient. So I'm going to call it a refractory ascites in a patient, and these are the people who are vulnerable to development of hepatorenal syndrome. Now let us see what actually happens in these patients serially. I am today describing a patient who is having refractory ascites. Like I have shown here a patient, he is alcoholic or it could be non-alcoholic. I've shown a malnourished patient, right? And I've shown him with the everted umbilicus, with the umbilical hernia, and you can see the bowel loops which are floating in this massive ascites fluid. Now the problem with these patients is that I need to plan a large volume paracentesis with albumin for these patients, and that might take some time because lots of time there are only limited number of residents in the casualty, and when this patient has come, we were dealing with, let me say, a head injury patient or maybe a myocardial infarction patient. So patients of ascites are usually given less priority, I would say, as compared to cardiology case or a neurology case, and that is where the problem begins, because this bacteria E. coli which is present in the bowel, this can actually exhibit a translocation. What you need to understand is that all this is stepwise. First you have ascites, then becomes massive ascites, then it becomes infected, that is spontaneous bacterial peritonitis. So there is a translocation of E. coli into the mesenteric lymph nodes. And from the mesenteric lymph nodes, this bacteria is going to reach up to the ascitic fluid, and once there is bacteria in the ascitic fluid, there would be development of pus. So therefore there is infection in the ascitic fluid, and that would translate into development of systemic inflammatory response syndrome in a patient. There would be a development of sepsis in the patient. There would be development of septic shock in the patient, and that will compromise the renal function of the patient. Why? Because septic shock per se would reduce the perfusion of the kidney per se. The best drug for management of spontaneous bacterial peritonitis, which has now occurred in the patient would be cefotaxime. Please remember that most of the time the spontaneous bacterial peritonitis as a disease is monomicrobial, whereas if it is gonna be 2 or 3 organisms isolated from the peritoneal fluid, then it is mostly due to perforation of the intestine, but in this case SBP, it's a monomicrobial infection, and that's usually due to E. coli, as I have mentioned. So patients who are having spontaneous bacterial peritonitis, they would be having features of fever and development of tachypnea. There would be tachycardia, there would be leukocytosis occurring in a patient, but as the patient goes and progresses towards septic shock, there can also be development of altered sensorium in a patient. So if you're having a ascitic patient with the altered mentation, that definitely means the fact that there is a hepatic encephalopathy component to the disease, and apart from that, even the septic shock component can contribute to decreased perfusion of the vital organs, contributing to this deterioration. At this point of time, most of the time, you as a doctor will also notice that this patient will be having a increased value of serum creatinine. That is mainly because of the renal failure component that comes up. The serum creatinine in this patient will usually go more than 1.5 milligram %. Now the problem is that a lot of these patients are malnourished patients. So even if serum creatinine, for example, is 0.5, what I'm saying is because this is a muscle wasted patient, so therefore serum creatinine is, let me say, 0.5. That will look like normal to you, but if it increases by 0.3, like suppose in the morning it was 0.5 milligram % in a wasted malnourished patient, but it is upgraded by 0.3 milligram % over the baseline value in a matter of let me say 6 hours. The rise is occurring in a matter of as little as 6 hours, and the urine output of the patient is decreasing to 0.5 ml. You know, normal urine output is 1 ml per kg per hour, but here the urine output of the patient is decreasing to 0.5 ml per kg per hour. That is a development of oliguria and anuria in a patient. So what I'm saying is increase of serum creatinine beyond the normal limit, or a rise of 0.3 milligram % over the baseline in 6 hour period with a 50% decrease in urine output, that means the fact that the patient is having a development of acute kidney injury, and that means that he's gone into hepatorenal syndrome. Basically, you need to understand the fact that HRS as a condition is a complex interplay of two things. The two problems that will always occur in this patient would be, one, that in this condition the vasoconstriction in the renal circulation, renal vasoconstriction per se, is increased and the systemic vascular resistance is reduced. What I mean by decrease of systemic vascular resistance is that the blood is diverted towards the splanchnic circulation. So you are having rather development of underperfusion of the kidney secondary to two reasons. One would be that there would be a vasoconstriction of the renal circulation that will obviously decrease the blood supply, but if you decrease SVR, the renal blood supply would be further compromised, so it's like a double insult to the kidney. Well, why is this all happening? Though there's a flow chart that's given in the textbook for it, but just to put it in simple words, I'll put it like this. Normally when we look at prostaglandins, the basic function of prostaglandins is that they are responsible for renal vasodilatation, and vasodilatation is a method of improving the blood supply to any particular organ. Now, if there is an increased urinary loss of prostaglandins, which happens in hepatorenal syndrome, then the vasodilatory activities would be lost and the vasoconstriction will increase. I repeat my statement, prostaglandins improve the blood supply to the kidney by causing a vasodilatation. In this condition, there is a urinary loss of prostaglandins, so the end result would be that the vasoconstriction mechanism will dominate over the vasodilation mechanism, and that is why the vasoconstriction in the kidney is definitely increased. And second, I would like you to remember that cirrhosis causes overproduction of nitric oxide. And this increased production of nitric oxide is then responsible for decrease in the systemic vascular resistance. So blood is diverted away from the kidney, which again explains the less blood supply to the kidney and contributes to hepatorenal syndrome in the patient. So the combination of splanchnic vasodilatation and constricted blood vessels, you see, I'll say like this. Suppose somebody is having heart failure, then cardiac output will be less, and if there's a decreased cardiac output, then there is a development of decreased blood supply to the kidney, and therefore there can be a renal failure in a patient. Pretty straightforward. Suppose a patient is having extensive amount of diarrhea and there is a fluid depletion in the patient, then again the blood supply to the kidney will become less and there would be a decreased urinary output. Traditionally speaking, there is only one factor that is contributing to decrease of blood supply to the kidney, and that could be like volume depletion, underperfusion, heart failure. But in this condition, hepatorenal, there are two factors which are operating. One is that the intrinsic blood vessels of the kidney are constricted and the splanchnic system is dilated. So the end result of both of them is that the kidney is not getting sufficient amount of flow that it should be getting to excrete out the waste products from the body, and that is why the serum creatinine value will tend to significantly increase in the patient. Now, coming to the patient's perspective, what is actually going to happen in the patient would be that patients of hepatorenal syndrome can either be having a type 1, which has a very fast deterioration. What I mean by fast deterioration is you first have development of ascites, it gets converted into massive ascites, then it becomes refractory to medical treatment. The medical treatment I spoke about was use of diuretics extensively. I have given extensive amount of diuretics and still the fluid is very much present, and I'm planning a LVP with albumin for the patient. Unfortunately, before I could do this, the patient went into spontaneous bacterial peritonitis and then he went into septic shock. So this sequence that I have mentioned here before you, if it occurs very fast in type 1 hepatorenal syndrome, in fact, it can occur so fast that most patients would die within 2 weeks and upper limit of 10 weeks. So the manifestations of renal failure would set up very fast in type 1 hepatorenal syndrome. In contrast, when it comes to type 2 hepatorenal syndrome, the median survival rate of the patient would be something between 3 to 6 months, and we will get more time to plan for a liver transplantation in type 2 hepatorenal syndrome as compared to type 1. Now, what is the fundamental difference between type 1 and type 2 is only the progression of the speed with which is occurring, and spontaneous bacterial peritonitis may or may not be occurring in both the cases, or spontaneous bacterial peritonitis is not a prerequisite for development of hepatorenal syndrome. In fact, at 25% cases of hepatorenal syndrome, there is no spontaneous bacterial peritonitis. It is simply the fact that due to the imbalance between the mediators, as I said, that is the vasoconstriction and vasodilation of the kidney is compromised. The imbalance between the vasoconstriction vasodilation system results in development of underperfusion of the kidney, and thereby results in manifestations of uremia in the patient. When you examine these patients, you could be having certain stigmata of chronic liver disease. In the first image, you can very well see a very characteristic palmar erythema, which can be seen in this particular patient, which is very prominent, especially in the hypothenor areas and then in the thinner areas. So palmar erythema is a very characteristic feature. You can also notice a bit of a contracture occurring here with respect to Dupuytren's contracture. Another feature that might be noticed in these patients would be white nails, that would be leukoonychia. So I'm pointing towards the findings that would be noticed in the hands of patients who are having stigmata of chronic liver disease, and these patients will then deteriorate into hepatorenal syndrome. You can see that here I have shown a presentation of a patient in whom we have made him outstretch his hands, and the patient would be having a definitive hepatic flap, that is asterixis, which would be a very reliable feature of metabolic encephalopathy. So features in the hands of these patients are palmar erythema, white nails, asterixis, and you can also get clubbing in the patient. These are the hand manifestations of the patient. If you examine the head and the neck area and the chest area of the patient, you will be able to notice presence of spider nevi. Spider nevi is due to overexpression of estrogen. The area where spider nevi is checked is mainly the head, neck and the chest area, and it is found in superior vena cava distribution. This medical condition, spider nevi per se, can also be found in rheumatoid arthritis in pregnancy. So it's not a very characteristic manifestation, but yeah, still worth the point remembering. You can also see presence of xanthelasma, which would be found with respect to the orbital skin of the patient, and there would be bad smell of mercaptans and ammonia, that is fetor hepaticus, coming from the patient. As you go down in the physical examination, you will notice regarding these veins which are seen over the anterior abdominal wall, especially the snake-like veins that I have shown here. in and around the umbilicus of the patient, and these veins that I have shown here before you are having a snake-like appearance, and the flow is away from the umbilicus. The flow is away from the umbilicus. Yeah, that's a very characteristic feature, caput medusae, and indicates photosystemic collaterals. So in all of these patients, you would be having is a presentation of stigmata of chronic liver disease, and along with this, the highlight would be a development of uremia in the patient, which would be highlighted by elevated serum creatinine, which I repeat again is more than 1.5 milligram percent absolute. In lot of malnourished patients, if the values like 0.5, 0.6 something, that might look normal to you, but then if it upgrades by 0.3 over the matter of one day, or I am saying as early as 6 hours, with a 50% decrease in urine output, that's definitely a cause of concern. And the major mediators behind all of this are nitric oxide, which decreases systemic vascular resistance, and urinary loss of prostaglandins, which explains the intrinsic renal vasoconstriction which is occurring in this particular patient. So now let us look at what are the diagnostic criteria for this particular condition. To understand the diagnostic criteria, I'll just try to first explain it in a slide before you, and then we come to all this medical literature which is mentioned here. So the first and the foremost thing that you need to understand is that all patients of hepatorenal syndrome would be having a low GFR. Now, one way to identify low GFR is elevated serum creatinine of more than 1.5 milligram percent, the baseline value, or you can also check for the creatinine clearance of the patient, which should be less than 40 ml per minute. So how do I know person is having low GFR? Either of the two methods, that is elevated creatinine or serum creatinine, is sufficient in a patient of pre-existing liver damage. In this patient in whom I've demonstrated that there is a low GFR, what I will do is that I will put in a center line. I will also put in a Foley's catheter, because I now need to plan out the urine, or I need to plan out whether the kidney is going to respond to the fluid channel that I'm going to give or not. And I'm going to give to the patient now 1.5 liters of normal saline through the center line. Under normal circumstances, when you give a fluid challenge to the kidney responds by diuresis. But in this patient, when I have done this plasma volume expansion by giving 1.5 liter normal saline to the patient, the kidney will refuse to meet the challenge, and in fact there will be no change in the GFR of the patient. There would be no change in the creatinine clearance of the patient. There would be no change in the urine output of the patient. So that means the fact that the patient's kidneys are not responding as they should respond normally. So first and foremost is demonstration of low GFR. Second criteria is, or second feature is, that the kidney is failing to respond like a normal kidney, that is to a fluid challenge. Apart from this, I also need to demonstrate, because this is the diagnosis of exclusion, so I need to demonstrate that there is no fluid loss in the patient. I need to demonstrate that there is no presence of any other cause of underperfuse the kidney, like cardiogenic shock should not be there, or I can say like this neurogenic shock should not be there. So I'm trying to rule out other pre-renal causes which are possibly affecting the kidney parenchyma, and they are obviously to be excluded. Then I also need to demonstrate that there is presence of proteinuria, but the magnitude of proteinuria should be less than 500 milligram per day. And along with this, if I do ultrasound in the patient, the ultrasound should be showing no parenchymal damage. That is because we want to rule out the intrinsic causes, and the ultrasound should also not be showing any reflex uropathy or nephropathy. That reflex uropathy is because I want to rule out the post-renal causes. So let's evaluate. What I've said is GFR is low, does not respond to a fluid challenge the kidney. There is no pre-renal causes, there are no post-renal causes, and proteinuria less than 500 milligram. That is what is called as the major criteria for this condition. So that's what is written in these 4 points. I deliberately decided to just write them down because I wanted to explain to you what is going on for diagnosis of this patient. Please appreciate this is the diagnosis of exclusion. The minor criteria are also there, or the additional criteria are also there. That would be urine output should be less than 500 ml per day. That's very logical. No? I mean, after all, we are talking about hepatorenal syndrome, so urine output should be less. Then you need to remember the following facts. Urinary sodium should be less than 10 and urinary osmolality greater than plasma osmolality. This is because this is classified under the pre-renal causes of acute kidney injury. So since we are classifying it under pre-renal cause, if you attend the kidney lecture, you will notice that in the pre-renal causes, urinary sodium are low. In contrast, if it is a condition where the tubules are damaged, you see, like in tubular necrosis, then urinary sodium is higher because salt is not absorbed. So urinary sodium is high in tubular conditions, and urinary sodium is going to be low in hepatorenal syndrome. Let me give you a diagnostic importance of this because of the fact that all patients of liver disease are having a deficit of production of clotting factors. You see, all clotting factors are produced in the liver. So chronic liver disease patient had a massive GI bleeding. I'm saying, for example, had a massive GI bleeding, and after massive GI bleeding, he went into renal failure. The urine output has dropped to, let me say, only 100 ml in the previous, let me say, 12 hours. When I have checked the urinary sodium of the patient is suppose 50, that is high, elevated. So this tells me the fact that the patient is having ATN, that is acute tubular necrosis, because if a person will bleed, then the blood supply to the kidney will be compromised and there could be acute tubular necrosis in a patient. This is not hepatorenal syndrome. How did I say that? First of all, there is a demonstration that there is a clear-cut hypovolemic shock occurring in a patient, resulting in a development of acute tubular necrosis, and the urinary sodium of the patient is high. So that means the fact that the tubules blood supply is affected, and that is the reason why I'm saying acute tubular necrosis. But hepatorenal syndrome is a diagnosis of exclusion. You need to rule out event like this. You know, if somebody had GI bleed and then he goes into renal failure, it is not hepatorenal syndrome. It is a massive ascites patient who's refractory to the diuretics that you use. That is when you would get a hepatorenal syndrome in a patient. So pre-renal causes is the findings which are seen in this condition, or findings of pre-renal type of acute kidney injury are found in this condition. And then are two very minor facts, that would be urinary RBC less than 50 per high power field. Normally you have less than 3. So hematuria may or may not be seen. If it is seen, it's a minor criteria. And serum sodium is lower than 130. That's because of the dilutional hyponatremia that occurs in all patients of hypoalbuminemia. So let us revise the additional criteria for this condition. Urine output should obviously be low, but then apart from the urinary sodium, urinary volume is also to be considered. Urine osmolality is also to be considered. The osmolality of plasma is 300. Here the urine osmolality can be about 500. That is a little more concentrated. RBCs may or may not be seen, a minor criteria. Normal is less than 3. Up to 50 can be seen in this condition. And serum sodium concentration of 130. That dilutional hyponatremia is the reason for it, and all major criteria should be present for diagnosis of hepatorenal syndrome in a patient, which I repeat once again is a diagnosis of exclusion. Now, what are the treatment modalities we have for this condition? Well, we have limited the treatment of choice is obviously liver transplantation in our case of decompensated cirrhosis, but we do have drugs. Now, what do these drugs do is that they basically cause vasoconstriction of the splanchnic circulation so that the blood supply to the kidney becomes relatively better. So midodrine and octreotide are the two weapons that we have to neutralize the splanchnic vasodilation of the patient. In fact, earlier what they were doing were that they were trying to neutralize the renal vasoconstriction. Why? They were trying to think that renal vasoconstriction is the main culprit behind it. Yes, it is a culprit. So what they did was they started giving dopamine infusion because dopamine has a vasodilatory activity, and they also gave prostaglandin infusions for this condition. However, the success rate of dopamine and prostaglandin infusions for these patients have been usually a failure. I mean, we have not been able to preserve the kidney function of the patient in spite of using dopamine and prostaglandin infusion. So currently the approach is not regarding that we should try and neutralize the renal vasoconstriction. The approach is rather like try to get the systemic vascular resistance back to normal by using agents that will cause vasoconstriction, that is midodrine and octreotide. And these two drugs, they mainly act not on the renal vasculature but on the splanchnic vasculature. So both of them will improve the blood supply to the kidney, and thereby the function of the kidney will definitely improve. But this is only a bridge after all, and the definitive treatment is OLT, that is orthoptic liver transplantation for this patient. So this is a topic, guys, which anyway has to be remembered because it's a component of decompensated cirrhosis. The second part of the topic, guys, that I wanted to remember is called as hepatopulmonary syndrome, which is characterized by presentation of platypnea, which is breathlessness in sitting position. Now normally we have orthopnea, which is breathlessness in supine position and heart failure, but this condition has platypnea. So let us see how the disease evolves and what is the reason for pathogenesis of this disease. So let us imagine this to be a damaged cirrhotic liver. In all patients of cirrhosis, we will always be having excess synthesis of nitric oxide. Because of this nitric oxide, there are going to be certain changes in the lung vasculature, which can be understood like this. Imagine this to be alveoli, where the gas exchange would take place. I've shown the pulmonary vessels traditionally, like they show artery and the vein, and now what is going to happen is that to exaggerate whatever is happening in the lungs, I am showing nitric oxide is causing a vasodilatation in the lungs. You can see that as compared to the earlier caliber of the blood vessel, now the caliber of the blood vessel is increased, so the blood will be able to rush through this dilated blood vessel, and because the blood will rush through this dilated blood vessel, the chances of oxygenation of RBCs inside the blood vessels would be lesser. You see, this is a blood vessel where gas exchange is taking place. You can see the diffusion of oxygen. What I'm saying is that if you have dilated vessels in the lung parenchyma, there is a change in the ventilation perfusion ratio. Normal ventilation perfusion ratio is 0.8. Ventilation is 3.5 liters per minute. Perfusion is 4.2 liters per minute. That is normal 0.8. In this condition, the perfusion of the lungs is enhanced thanks to nitric oxide, and because perfusion of the lungs is enhanced, the ventilation perfusion ratio becomes lesser. That explains the hypoxia component. There are two ways of understanding it. Part number one to be understood is that cirrhosis is responsible for ventilation perfusion imbalance. Why? Because it causes vasodilation of blood vessels. The part two of the discussion is that the dilated blood vessels will have blood rushing through them, so the chances of oxygenation of RBCs would be relatively lesser, and we technically call it shunting. Normally in pediatric cardiology, we study left to right shunt and right to left shunt. This is also shunting, but here blood is not going from a chamber left side to the right side of the heart. It is simply that the transport of blood is occurring in a fashion faster, that the proper oxygenation of RBCs is not occurring. Therefore, the manifestation of this disease is technically called as platypnea. There is a change in oxygen saturation when this person will sit up and will come back to normal in supine position. The manifestations of this disease are very characteristic. The two terms I want you to remember are platypnea and orthodeoxia. Both of them are manifestations of hepatopulmonary syndrome and are one of the important features which are to be remembered for diagnosis of this condition. The triad for hepatopulmonary syndrome can be remembered in the following fashion. First of all, I said in this condition there is a arterial desaturation or arterial deoxygenation, in a sense that the blood has to travel faster, so the ability of the RBCs to get oxygenated is relatively lesser. This is secondary to intrapulmonary shunting. As I highlighted, I mean, we are not talking about any shunting from the cardiology perspective. We're talking about shunting from the perspective of the blood not getting oxygenated properly, and there should obviously be liver disease in a patient, that is cirrhosis. So if you get these three things together, arterial desaturation, intrapulmonary shunting and cirrhosis, then we say that the patient is having a hepatopulmonary syndrome. In fact, you can look at the textbook image here that can help you realize better what I am saying. They have shown the alveoli, they've shown these blood vessels across, and in this condition you can see there is a dilated capillary of the vessels. So dilated capillary or constricted, both of them are troublesome, because if the capillary or the blood vessels around the lungs are constricted, even then the diffusion is hampered, and if there is gonna be dilated vessels, again the diffusion is hampered. The condition that we're talking about is hepatopulmonary shunting or hepatopulmonary syndrome, is characterized by a development of faster transit of blood through this area, leading to less oxygenation. The manifestations of this disease is one, platypnea, which means that person would be having breathlessness in sitting position. Please do not confuse this with the orthopnea, which is encountered in patients of heart failure. And please do not confuse it with trypapnea, which is encountered in patients having a massive unilateral effusion. Orthopnea means that the breathlessness of the patient is exaggerated in supine. Trypapnea means that breathlessness of the patient is exaggerated in lateral decubitus position. When it comes to orthopnea per se, dyspnea increasing in supine position, that is a feature that is seen with heart failure. And lateral decubitus is unilateral pleural effusion. And one of the important reasons for unilateral pleural effusion happens to be malignancy or a cancer, which will explain the manifestations of trypapnea in a patient. Second is orthodeoxia. Orthodeoxia means decrease in oxygen saturation by at least 4 millimeters, or if you're checking by pulse oximeter, obviously by 5% if the patient changes his position from supine to upright position and is improved by returning to the recumbent. Recumbent would obviously mean the supine position. So let's get the data straight. Both of them are used interchangeably. Whether you say platypnea, breathlessness, which is increasing in sitting position, or you say orthodeoxia, where there is a decrease in oxygen saturation in sitting position, comes back to normal in supine position, they are after all the same, so it is written as platypnea orthodeoxia syndrome. Now, what are the causes for this? First of all, you should know a cardiac cause that is by the name of atrial myxoma that I've explained in cardiology, and I'll just do a quick shunt for it so that you can remember the manifestation. I had drawn a representation like this showing the fact that the tumor, which is suspended in the lumen of the left atria, when the blood will come into the atrial chamber, it will cause this tumor to move like a pendulum and it will strike this mitral valve leaflet. Now you can see the fact that the tumor is causing obstruction of the inlet of the mitral valve, and if the person is sitting up like I am at the moment, then due to gravity the tumor will have higher chances of causing obstruction of the inlet of the mitral valve. So the congestion will be more in sitting position, and more congestion in the heart in the sitting position will contribute to development of breathlessness in the patient, that is platypnea. So atrial myxoma is one of the standard causes that I wanted to remember. Another cause I wanted to remember is ASD, atrial septal defect. So primarily ASD and atrial myxoma are two cardiac conditions where predominantly you can be having platypnea. Then pulmonary diseases which are related are hepatopulmonary syndrome, which is secondary to liver cirrhosis, or it could be arteriovenous malformations in the lungs. Arteriovenous malformation in the lungs, which are to be remembered, are ones which are secondary to either parenchymal lung diseases like Osler-Weber-Rendow syndrome, or for that matter of fact pulmonary emphysema, which was the first disease in which the manifestation of platypnea was explained. Other could be like interstitial lung disease also. So these are some of the important causes for platypnea that I wanted to remember. What are the important ones? ASD I wanted to remember, not all of them obviously. Atrial myxoma, hepatopulmonary, pulmonary arteriovenous malformations like Osler-Weber-Rendow syndrome, and then is emphysema, which is the first case where it was reported. Interstitial lung disease again could be having this manifestation. So these are some of the important causes of platypnea orthodeoxia syndrome that you should be aware of. Okay guys, another reason why am I teaching this topic of hepatopulmonary syndrome is to make you also sensitized to the investigational choice for this condition, that is called as bubble contrast echocardiography, because it's a very peculiar term. So I thought I'll just explain the basic principle behind it. In bubble contrast echocardiography, we push agitated saline. This agitated saline would be pushed into the right chamber of the heart via the antecubital vein, and the usual query of most doctors is that would it not cause air embolism? Well, the answer is a no, because the amount of air that will go into the heart will be very minuscule, but it will help you pick up any shunt in the heart and would also help you know whether there's a shunt in the lungs, in a sense that there would be a faster traversing of blood across the pulmonary vasculature. So we can simultaneously use Doppler to measure the speed with which the blood is moving across the lung vasculature and identify the arteriovenous shunting that is occurring in the lungs of the patient. If you look at one of the image that is shown here, you can see that this is the left ventricle, this is the left atria, this is the right atria, and some part of the right ventricle can also be visualized. So this is definitely a normal heart that I have shown here before you, and the chambers are the ones that I have shown on a echocardiography. Now, when agitated saline using a three-way stopcock is pushed via the antecubital fossa into the body of the patient, you can notice a very clear-cut opacification of the right side of the heart that is happening because the air is going into the right side, but you can also see some bubbles of air escaping into the left. If you compare the two images which are shown here, you will also notice that the amount of bubbles that have escaped into the chamber of the heart here have dramatically increased as compared to earlier. This is because this person is having a shunting of blood from the right atria to the left atria, which is by the name of PFO, that is patent fossa ovalis. So for small structural defects like ASD or patent fossa ovalis, one of the tests that is useful is bubble contrast echocardiography, and the same technique can also help you identify the topic of our interest currently, that is hepatopulmonary syndrome, where there would be a faster transit of blood across lung parenchyma, as I have explained. For management of this condition, the definitive treatment is obviously OLT, that is the orthoptic liver transplantation. Though for survival in these patients, we will have to use positive pressure ventilation so that at least we can tide over the current crisis, especially the desaturation that is occurring of severe level in this particular patient. And as early as we plan for OLT, the better for these patients. So two complications of decompensated cirrhosis that I want you to remember are hepatorenal and hepatopulmonary that have been covered in this lecture. So keep hammering, guys, keep working, and I'm very sure you are on the right track, and I'm very sure that you would come out with flying colors. Thank you so much.